My name is Jeff Leto. I'm the design lead as well at Wellahealth. I'm privileged to be giving this presentation at UXDX Africa community meetup, and it's so amazing to be discussing something that's very important to my team. From the topic, you can see that I'm going to be discussing from physical to digital, creating an effective user journey. So I'm going to be sharing a story of how our team as well as developed a successful customer journey map that reduced the typical 4-hour physical experience to a 15-minute digital experience. And as we go along, we're going to see how this happens. But a brief of what we do at Wellahealth. So Wellahealth is an health technology company. We work with insurers and pharmacies to make sure that healthcare is delivered very affordably and accessibly to Africans. So we do two main things. We run a microinsurance platform, and we also do pharmacy benefits management. So to give a bit of overview of what microinsurance is, it's delivering bite-sized insurance to Africans. It helps people who can't afford to pay for comprehensive insurance be able to still have access to comprehensive healthcare by paying a smaller amount of money every month. While pharmacy benefit management means we help insurers to have access to drugs from pharmacies all across the country. So the problem we noticed while we started Wellahealth was that last mile quality healthcare delivery to the largely poor African population is really, really expensive, and also is not so accessible. For example, I'm a Nigerian and I live in Nigeria. One of the major problems we have in this part of the world is that it takes a very long time for people to be able to access quality healthcare. And by quality healthcare, I mean people that visit secondary and tertiary health institutions to be able to access care. And these are not even for really serious illnesses. We are talking about common illnesses like malaria, like typhoid, like infection, cold and fever. People need to walk long distances to commit to hospitals to get or take use different kind of means of transportation to get access to this healthcare. And when they even get to the hospital, they need to spend a lot of time waiting to be seen by a doctor. And we were able to delineate certain reasons for why this was happening. And some of them, one, is high patient load in these secondary and tertiary health institutions. And also, most of the people that were coming for treatment in these places that were supposed to be meant for treating way more serious illnesses were coming for cases such as malaria. So 70% of our patients' clinic cases were because of malaria. And also, the centers that are supposed to be taking care of these common illnesses, which are called primary healthcare centers, are sparsely distributed in Nigeria. Primary healthcare centers were designed to be localized to certain communities so that people can easily just walk away from their home and go to an healthcare center to get treatment. But one, they are not functional, and two, they are not so evenly distributed around the country. Then there's very high patient to doctor treatment load. So a doctor in Nigeria, I think one doctor is supposed to see about 4,000 patients when you compare the number of doctors we have in the country versus the population that we have in the country. So that makes the workload very, very high for doctors. So we needed to think of a way to solve this problem. And we call them wicked problems because we realized that when we've solved one, a new problem came from the solution we made. But that hasn't deterred us from trying to make sure that we found the solution to this. So at our team, Wellahealth, what we do is we use design sprint sessions to discuss our problem. To discuss problems we've noticed and find solutions to them. We have an internal team philosophy that we need to experiment fast, push out solution, and iterate on the fly so that we are learning as we progress rather than spending a lot of time thinking about solutions. We rather come up with a solution fast, push it out, and start seeing what the result is going to be. So, but like I said, we use design sprints. But the typical design sprint session is supposed to last for 5 days. Unfortunately, that doesn't happen in our team. We recently became 34, but when this was happening, we were just 10 in the team. And that means that we have a lot of work on our hand, and being able to do this, we definitely need to modify what our design sprint sessions are going to look like. So we shortened them to 3 days. Now, within those days, we have to, go through the entire process of what design sprint sessions should look like. So we try and understand the problem that our users are having or our potential users, start ideating around it. Once we've comes with a possible solution, we start designing those solutions, we prototype and we test. So we had a group of users that came in and tested our proposed solution, which I'm going to discuss as we go on. But the ultimate goal of that particular sprint session for us was we wanted to design a service that will allow people to be able to, go from spending 3 to 4 hours trying to access healthcare that is supposed to be, very easy to access, to making sure that it doesn't last more than 15 minutes for them to be able to get it. To give you an idea of how the 3 to 4 hour physical journey looks like, we'll be using Mrs. Amaka as an example. Ms. Amaka is a 30-year-old Nigerian woman. She owns a petty store in Bagada. She's married with 3 children. And let's discuss what a typical journey for her to be able to access care would look like. So say Mrs. Amaka has fallen ill. She's feeling sick now, and she wants to get quality treatment. So the first thing she does is she needs to now go to the hospital. But here's the problem. There's a lot of traffic in Lagos. She needs to brave that traffic, probably jump buses, commute with people inside crowded buses to get to the hospital. So you know how Lagos traffic is. She spends hours on the road. Or say she spends 45 minutes on the road. She gets to the hospital. On getting to the hospital, there are other people that have come looking to speak with the doctor. So she needs to sit in the waiting area and wait, says another 1 hour before she can speak with the doctor. Finally, she gets to speak with the doctor. And after the doctor has taken her history, examined her, he says, "Oh, I feel you have malaria typhoid, but we need to confirm this. So let's do a test." Now, what Ms. Amaka we need to do is the doctor writes a test order for her. She needs to go to the account department in the hospital to pay for the test. While she's there, she has to wait on a queue again because there are tons of people in that secondary healthcare center that needs to access the account department also. So she joins another queue. That's another long waiting time. After she has joined this queue and she successfully paid, then she needs to go to the diagnosis center to take a test. And if you have an idea of how Nigerian secondary and tertiary hospitals are built, they are not well structured. So we're talking about walking distance of 10-15 minutes sometimes to get to this largely separated areas of the hospital. So she walks, she gets to the place, then she needs to join another queue to be able to access test again for malaria or typhoid. Then when she test is done, she has to wait again to collect her test results. She needs to take that test result by hand, by herself, to the doctor. She takes this, goes back to the doctor, and joins another queue again because some people are already waiting for the doctor to read their test. Then finally she gets to see the doctor, and the doctor writes a prescription for her. Now it has been confirmed she has malaria. So what does Amaka do? She needs to take that prescription, go to the hospital pharmacy, wait on a queue to pay, and collect her drug again. This is a very, very tedious journey, and it is quite expensive also. Expensive in terms of the amount she's going to spend, expensive in terms of the time she's going to spend. So usually this kind of journey takes 3 to 4 hours for people to be able to access care for cases that are supposed to be managing primary health care centers. So we empathize with people that were going through this, and we knew that we needed to do something about this. So the question we had in our mind is, how do we optimize the service design so that we can deliver quality healthcare at the shortest possible time? Case in point, we noticed that the major problem that was causing this was that healthcare centers, when usually have high number of patients and are overwhelmed with the number of patients that they have, and also the hospitals are poorly designed when it comes to infrastructure. So how do we make sure that people get something quality health care rather than spending such a number of time trying to get that care? So we came to 2 conclusions. We needed to identify new treatment touch points and processes, and we needed to find a way to make sure that the payment is faster and is affordable for this largely poor population of the country. And that was what our major user journey mapping goal was. So now, identifying the treatment touch point and process, the first thing we noticed while we were doing our design sprint and speaking with our customers was that including the health stakeholders and general population, everybody, because they do not want to go and spend so much time in the hospital to see a doctor, they first visit a local pharmacy store to get drugs. So in malaria is a very common illness. So when you start having fever, headache, even cough, the first thing people do is let me go and speak to a pharmacy. So they go to a pharmacy store and just tell them, I'm having a headache, I'm having this. And the pharmacist just prescribe drugs for them. They go and they take drugs. Sometimes they feel better, sometimes they don't. So usually the people tend to go to hospital after they've tried this particular um, treatment behavior and they realize this, okay, I'm not getting well. That's when they decide to go to the hospital. But there was a problem with this. Most people were just getting drugs and just using malaria drugs. And the reason why prescribing malaria drugs is so easy in Nigeria is because malaria is a very rampant illness. There are over 80,000 deaths yearly in Nigeria because of malaria. So WHO made it pertinent that malaria drugs are easy for everybody to access. And because of this, there's a lot of abuse. People tend to become resistant to malaria drugs because people just use it illicitly. Sometimes they don't even complete their treatment, they just stop it. So we know that, okay, there's a major problem with our ethical behavior. But rather than try to change that, why don't we build on that? So we realized that we needed to use local pharmacies as primary healthcare centers when it comes for common illnesses like malaria. So we found out the user behavior, then we needed to build on it. But here's the thing: we need to make sure that that treatment is actually comprehensive. That means there's a diagnostic test and there's a treatment that actually works. And that's the part where we now need to work with local pharmacies for this to happen. So we started reaching out to pharmacies, started signing them up, and started training them on how to effectively manage malaria. We came up with drug formularies that actually works for malaria, with treatment options that works for malaria, and we taught them on how to use something called RDT, rapid diagnostic text, that actually brings the result out in 10 to 15 or 5 minutes. So it is 99% accurate for malaria test, and they can easily do it with a needle prick, blood sample, and the pharmacist can easily just determine if that person has malaria or not. And that's effectively reduced people taking drug illicitly without, confirming if they truly have malaria or any other illnesses. So the second thing we needed to do was to make sure that we created a faster and affordable payment system. So most people actually pay out of pocket for healthcare in Nigeria. That means that we needed to work with larger insurance companies to make sure that we provide affordable quality care to Nigerians. So that was when we came up with something called Wellahealth Malaria Care Plan. It's a micro insurance plan that allows people to be able to pay as little as $1. That's 500 or something naira um, for every month for their for treatment for different kind of common illnesses, and that has allowed over 4,000 people to be able to have access to our microinsurance plan, and that number is growing every day. In fact, most of the people that usually use the microinsurance plan are people that are getting insurance for the first time in their life. So that's made things easier for a lot of people to be able to access care. But also, we discussed how crazy it was to be able to pay. So we decided to create a lot of digital channels for people to be able to access, to make payments. So you can easily go onto our website and make your payments. And also we started working with local agents. So for people that don't know how to use smart mobile phones, they can easily walk up to the local agent and pay for their Wellahealth care. Now, solving the challenge. What happened after we came up with this solution is that now Ms. Amaka tends to get achievement in 15 minutes. So let me walk you through what happens in comparison with the physical journey. So Ms. Amaka has subscribed to Wellahealth microinsurance plan now, and she has fallen sick. So what does she do? She picks up her phone, calls Wellahealth, or use her USSD account and requests for treatment. Or she goes to our website and requests for treatment. The moment she has done that, we get notified at the company, then we send that to a local pharmacy for test and treatment. So now, this is the amazing thing. Mr. Amaka would have actually gone to a pharmacy in the first place, but this time around, we are the ones sending her. So we send her to the pharmacist. We inform the pharmacist of the person that's coming because we've triaged her. We know she likely has malaria already. So she gets there. The pharmacist takes history, um, takes a blood sample, tests it with RDT, and that gives them the results. And instantly, if you confirm that she has malaria, it gives her malaria medication. If she doesn't have malaria, she still gets some form of medication for pain relief and other things. And even if you want to speak with a doctor, she has access to telemedicine that she can easily call and speak with the doctor if she's not fully satisfied with what the pharmacist has done. But what usually happens is people do this, they get their drug, they go home, they get treated, and they're usually happy. And this all happens within the space of 50 minutes. So this really solved problem for a lot of people. Most of the feedback that we've gotten from people that have been on our platform has been that they are so happy now. They are not spending so much. They're paying less than 500 naira every month, and also they are spending very little time commuting to access care because they can easily walk 10 minutes to a pharmacy in their area and get treated. But there have been challenges, not to lie. There's no way we could have done that usual journey mapping and solved all the problems. So part of the problem we had initially was we didn't have enough pharmacy coverage at the beginning of the entire process. So we had a lot of discrepancy subscribers because we sometimes had to send them to pharmacies that are partnering with from them, or we needed to activate pharmacies on the fly right there for them to be able to use. But our pharmacy network has increased to over 5,000 now, and that makes a lot of sense for us because people now can easily access care. And that's some of the things we needed to like fix, how to form better partnership with pharmacies. The RT test kit that were being used also were not field proof. Sometimes they used expired ones, and so sometimes false negative results came from some pharmacies, and they were not abiding by our treatment directory. So we needed to work with pharmacies to make sure that they actually treat people the Wellahealth way, and that is still ongoing. There's no way that's going to happen. Also, part of the challenge we had is, the example I gave was for people in Lagos. We didn't think about people in places like Ikotepene and some other part of the country. And we had that challenge this year because we expanded our service to Ikotepene, and we had people saying things like they had to go to a village to draw blood sample, take it to the city center for people to be treated, for people to be tested for malaria. So we needed to start thinking around that. How do we modify our service design to include these people that don't have access to pharmacies around them, that do not have access to diagnosis centers around them? So we started building experience centers. So we currently have one in Mekotepene that was launched a few days ago, where people can now walk in, actually speak with the pharmacists, is leading now getting access to more pharmacy centers around the town and this environment. And also now people can actually have physical contact with who Wellahealth is. And initially, like I said, we were thinking around malaria alone. Now there are other common illnesses in the country that people actually need to find a way to treat for. So now we started modifying our treatment regimen and started including all these things like typhoid, headache, and other ailments that people usually have commonly in this part of the world to make sure that those things are included in our plan. So and we are gradually growing. So thank you so much for your time.